everyone. Good morning in Sweden time and good afternoon in Yogyakarta time. Welcome to the workshop on Introduction to Sleman Health and Demographic Surveillance System. I am Lutfi Azizatunisa. I'm a junior faculty member at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Will be the MC for today's workshop. This workshop aims to introduce Sleman HDSS to the students as well as lecturers from University of Gothenburg and also the Master of Public Health program in Universitas Gadjah Mada. The participants of this workshop consist of the students, the lecturer from both institutions. And this workshop is one of the activities under the collaboration between Universitas Gadjah Mada as well as University of Gothenburg. Before we start the main agenda of this workshop, allow me to read the rules of the workshop. Dear the participants, please make sure that your displayed name is your real name. All the participants will be muted during these presentations, and those who want to ask to the speakers, you can drop your question in the chat box using this template. Please mention your name, your affiliation, to whom your question will be addressed to, and your questions. Your question will be answered in the discussion session after the presentation. And those who wish to ask directly to the speakers, please raise your hands and the committee will open your mic later in the discussion session. You may ask also in Bahasa Indonesia and we will help to translate your question. All participants can access the presentation document in the Sleman HDSS Google Classroom. The link provided in the presentation as well as HDSS Sleman committee has also invited you in the classroom via email. And this is our agenda for today. The workshop will be started with the introduction of the collaboration between Universitas Gadjah Mada and University of Gothenburg that will be explained by Dr. Monica Hertzberger, and it will be followed by the introduction to Sleman HDSS that will be delivered by Dr. Ifta Choiriyyah. Data overview of Sleman HDSS will be presented by Dr. Ema Madyaningrum, and the discussion session will be facilitated by Dr. Gadjah and the workshop will be closed by taking photo together at the end of the workshop. Okay, let's move to the first agenda. We will hear the explanation of the introduction, the collaboration between Universitas Gadjah Mada and University of Gothenburg from Dr. Monica Hertzberger. Dr. Monica Hertzberger is a registered dietitian and public health nutrition epidemiologist. She is a researcher and lecturer in the Department of Public Health Epidemiology and Social Medicine at the University of Gothenburg. She has research interests in lifestyle and obesity prevention or intervention. Dr. Monica, the time is yours.
Oh, thanks a lot. Thanks for the nice introduction. I just wanted to say hello and thank you very much for starting this collaboration that we have been dreaming about for a long time. So we're excited to finally be talking about collaborating. From our end at the University of Gothenburg, we've invited students in our Masters in Public Health and Masters in Global Health from both the first year and the second year. And I just wanted to say that for the first year students, we hope to inspire you with topics that you might work with in the future for either a practical experience or for your thesis work. And for those of you in the second year that are thinking about the thesis course quite soon, because it starts in January of 2022, that we'd like for you to consider one potential option might be to find a collaborative project working with the HDSS data. So we're excited to learn more about it, and I won't take up any more time. I will turn it over to Dr. Ifta Choiriyyah to introduce HDSS. Thank you.
Thank you so much, Dr. Monica, for the brief introduction of the collaboration project. Now we move on to the introduction of the HDSS Sleman. We have here Dr. Ifta Choiriyyah. Dr. Ifta Choiriyyah is the chairperson of the Sleman HDSS. She is medical doctor by training, and she holds a Ph.D. degree from Johns Hopkins Bloomberg School of Public Health in the United States. She has research interests in reproductive sexual health and population health. Dr. Ifta Choiriyyah, the time for presentation is 15 minutes. The time is yours.
Thank you so much, Dr. Lutfi, and thank you also for the introduction, Monica. So I'm very pleased to be present today to provide an introductory session about HDSS Sleman. So this is just the beginning of our maybe series of workshop that we hopefully will be able to manage, organize, and offer to all the students who are interested in working or using HDSS secondary data set, or also using the HDSS sites to do fieldwork studies. So without further ado, so this is my presentation. We will provide opportunity for discussion and also questions later after our presentation. So my name is Ifta Choiriyyah. I'm from Department of Biostatistics, Population and Epidemiology, and I've just I have been transferred for the coordinating activity for HDSS Sleman this year from Dr. Fatwa Sari Tetrasari, who is also present in this session. So hopefully this introduction session will be a venue for us to have an initial understanding about the scope and the work of HDSS. And at the end of the October, we hopefully, after this, we will hopefully can circulate some like survey for students who are interested or maybe have identified the topic of the study they want to pursue using HDSS data. And then later on, maybe at the beginning of next year, we will develop more longer workshop series using in-hand data that's already maybe distributed, so students can readily use and practice, manage, and analyze the HDSS data set. So this is the Sleman HDSS, is a health and demographic surveillance systems that is initiated and funded by our own Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada in 2014. This is a longitudinal population study at household level in Sleman Regency, Yogyakarta region in Indonesia. So we are now in the 7th cycle of data collection, the first one in 2015, and we include about 5,000 households, with about 19,000 household members within the household. So the aim of this HDSS Sleman system is to develop a surveillance set that can provide demographic and health status data in Sleman Regency to mainly inform policy making, to engage in community empowerment activities, and facilitate other educational activities within the School of Medicine, Public Health and Nursing. We also want to provide a database of demography and health status, which can be available for public use by researchers and students in Gadjah Mada and our partner institutions. So this is Indonesia. So we are like an archipelagic country with more than 13,000 islands. We are located in the middle of Java Island here. This is Yogyakarta province. This is a very small province actually, but because we are in the middle of the Java Island and more than 60% of Indonesian population actually reside in Java. So this is our province. UGM is in the middle, like right in the middle of this this region, and our HDSS site is within the Sleman Regency here. So this is Sleman Regency. So our HDSS site includes all the villages in Sleman Regency. We use sampling frame from the National Statistic of Indonesia to have the list of enumeration area, and we randomly selected 216 enumeration area with 25 households selected within the enumeration area. So that's why we have about 5,000 households within the HDSS system. This is our day-to-day management team. So although my title is chairperson, but I'm actually more kind of like coordinating all the activities within the division. So we have a project manager who mainly generate and supervise content production, and we have data collection to assist with data collection activities, which is our main activities, and also data utilization for students, researcher, and our partners who wants to engage and use our data set. And the other division that is very important also for us to continue working in HDSS side in Sleman is stakeholder engagement, because we want to make sure that government and the community within the HDSS actively engage and give support and also input for us, so our data, our research is relevant and actually useful for our community, because the main aim for us is to improve the population health in Sleman. We also have quality control division who assist and supervise with all quality decision making about data and utilization. So this is our cycle of data collection and analysis and dissemination. So of course, we start with data collection, with planning and preparation to do data collection annually. Usually we do it at the beginning of the year until the middle of the year, but due to COVID-19 this year and the surge of COVID cases due to Delta variant, we have to postpone, and actually we are just starting the 7th cycle at the end of this month. And then we will clean and manage the data set so it's ready to be used by our researcher affiliated in HDSS and to be offered to the faculty and researcher at the same year. So usually it's ready to be used at the beginning of the next year. And then we also do reporting and dissemination activities to all the organization and stakeholders that are relevant to our work and team. So this is our, so like I said, we have already 6 cycle of data collection, and the first sampling is 5,147 households, and we actually have a very high response rate, which is very common in developing countries because people are still very welcome and they are eager to participate in population studies. So we have pretty high, more than 90% response rate within the household. But in the last cycle last year, because of the pandemic and it's a very short window decision. So the management decide to do remote data collection using phone. And there are some challenges, for example, like a lot of household or individual actually change numbers several times, or they just don't engage too much with somebody they don't see their face asking them to participate in remote data collection. So our response rate is quite low, we only able to reach a third of the population. So that's why in the 6-7 cycle we decided to wait for the pandemic to ease down a little bit, and then we want to do field data collection face-to-face to improve the response rate and also reach out those who are in the lower socioeconomic status, because those who are in the lower socioeconomic status tend to tend to not to respond to our request to remote data collection. We also have individual panel started in the third wave. So we also have a quite high response rate for the individual panel module. So our sample size was decided to estimate the infant mortality rate of 25 mortality per 1,000 live birth. And then this is our number of respondents. So the household member within the 5,000 household is about 20. So it's around 4 per household. The 6 cycle, because of the low response rate, we only have like 7,000 household members covered in the cycle. So we use our own each data collection application, which is each HDSS. We also adopt the standardized questionnaire and system from the HDSS, because there are a lot of HDSS system right in the global arena, and they also actually have standardized questionnaires, and we do the application and use the data collection and perform the interview using our tablet. And it's included all the skip pattern, logical skip, so that interviewer can follow the flow correctly without any error. So we have 2 kinds of respondent for our HDSS data collection. First is household itself as a unit level, with a knowledgeable person within the household as a primary respondent. So it can be head of household, or usually like is the wife of the head of the household who know the situation of the household, that can answer fairly accurately about the situation of the household and the family members. But it's not always the same for each HDSS cycle, because sometimes there will be different people who are available for interview in each cycle. So this is the modules that we include. So it's all the main issues in health in developing countries. So we have demographic data, but also main topic in communicable disease, non-communicable disease, risk factors for the diseases, and access to healthcare. We also have a module in maternal and child health, including vaccination and breastfeeding and complementary food practice, which are asked for 2 caregivers of under 5-year-olds. So this is the main, maybe I would argue the main utility of our HDSS system is to update on demographic events. So it's death, migration, marriage, divorce, and birth, because in developing countries, Indonesia also, we don't have a very robust vital surveillance or vital statistics system, although in Yogyakarta is actually better than most of other provinces in Indonesia, but we want to complement that because we actually also do verbal autopsy for those deaths who are covered within our surveillance system to determine the cause of death. I think this is very useful because a lot of death in Indonesia is not sometimes it doesn't happen within a health system like health facility network. So maybe official cause of death is not always determined by medical doctor. So we do the verbal autopsy using the formula developed by WHO to determine cause of death. And also the basic demographic profile of household members, say sex, age, religion, ethnicity, education, and employment, and household assets to determine wealth index, to know the socioeconomic status of the household. We have collected it twice at the beginning of the surveillance in the first year and also in the third year. And the big health issue is the maternal child health and reproductive health. So we collected pregnancy outcome for the new household members, you know, the new baby, the newborn birth attendants, whether it's a vaginal or section birth, and the immunization status and breastfeeding status among under 5 years old. And for women of reproductive age, we also asked the full birth history and their contraceptive use. Other topic is infectious diseases, non-communicable disease, but I will admit that because of the limited resources that we have, because we funded ourselves, so we cannot do a lot of module in this HDSS surveillance system. So at the beginning, we only ask the knowledgeable household member to ask about whether any household member have this respiratory infection, dengue fever within the last month, or whether there is any household member diagnosed with hypertension, diabetes mellitus, etc. in the last 6 or 1 year. We also ask about access and utilization of health care services of all household members. And then starting in the third cycle in 2017, we started to include some individual modules, which we asked to one randomly selected household member using case sampling. So, you know, we selected the household, and then within the member of the household, we randomly selected one member, age 25 to 64. So this is adult member, about some of the modules. So we have in the third, in the third cycles, we have module on non-communicable disease and quality of life and chronic diseases risk factors. So consumption of food and physical activity, mental health, and also last cycle, we include the ad hoc module on socioeconomic impact of COVID-19, which also we will collect again in this cycle.
I'm sorry, Dr. Ifta, for interrupting. Maybe could you please make it?
Okay, yeah.
Thank
so
you
this is individual modules that we include for those samples. And this is the schedules. So we have used this schedule, but sometimes due to limited resources or due to the pandemic, some modules are not collected. But the main modules are collected every year, and some thematic modules are collected every 3 or 5 years. Yeah, and this is the actual realization of module administration. And we have several users, mainly our student in the medical doctor education or master degree program, and also our own researcher or faculty member use the HDSS data for their analysis project. So also we have, so for student researcher, including those who are outside of the UGM Faculty of Medicine, so we are also welcome them to use the HDSS data, but we limit those data who are at least 2 years for those who are outside FK-KMK UGM. The general requirements, you can check it in the Google Classroom. I think it's also posted there. Basically, we will also review it before we proceed with approval to make sure that there is no overlapping theme, etc. And then you have to go through the ethical clearance also before doing your analysis. We also welcome students or faculty who wants to do the HDSS side and infrastructure to do nested research. So sometimes they only want to do, some researcher want to do sampling frame to select subpopulation of HDSS, and then they can identify specific population, or they ask to add additional module in the main data collection cycle. Some researcher, because UGM is also heavy on community engagement, we really believe of engaging the community. They combine with community engagement activities. So we can provide assistance in permit obtaining and contact the respondent, also other aspect of data collection as mutually agreed in the partnership. And all the finance from these additional activities will be financed by the researcher, because we don't have a lot of funding for additional activities. So I think that's it. This is just some documentation of our recent activities from data collection and study exchange with other HDSS system, community engagement, and workshop. I think thank you so much for your time. I hope we can talk again in the discussion session. Thank you.
Thank you so much, Dr. Ifta Choiriyyah, for the comprehensive introduction of Sleman HDSS. Now that we understood that Sleman HDSS has collected data since 2016, now we will hear the explanation about the data overview of Sleman HDSS that will be presented by Dr. Ema Madyaningrum. But before that, I would like to introduce her. She is a scientific member of Sleman HDSS in the Data Utilization Division. She is also lecturer at the nursing program in the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. She holds a doctoral degree of Public Health from Taipei Medical University. Her research interests are in elderly, community nursing, and family nursing. Dr. Ema Madyaningrum, 15 minutes for the presentation. The time is yours.
Thank you very much, Dr. Lutfi. Good morning, Professor and students from University of Gothenburg, and good afternoon for my colleagues and students from Universitas Gadjah Mada. Today I want to present. Wait a minute. Okay. I want to present about data overview Sleman Health Demographic Surveillance System, or HDSS. In this overview, we have some topics. The topics include demographic, reproductive health, child and maternal health, breastfeeding, complementary feeding practice, immunization, vitamin A supplementation, communicable disease, non-communicable disease, and risk factor. And the last topic about data collection in 2020. First, about demographics. This is about Sleman HDSS population pyramid in 2015 and 2019. From this pyramid, we can see the blue one in the top pyramids. It's wider than the pink one in 2015. Is one the indicator that Sleman HDSS population is shifting into an aging population. Such as Dr. Ifta mentioned that Sleman is one of district in Yogyakarta province, and then Yogyakarta is one the high population for elderly population in Indonesia. And then about household socioeconomic status or the index by sub-districts in 2019. In the survey, we have 17 sub-districts, and the respondent who had the lower socioeconomic health status, mostly they live in Tempel sub-district, and the respondents who had the upper or higher socioeconomic status, mostly living in Kalasan sub-districts. For educational level, Sleman HDSS respondent aged more than 10 years old in 2015 and 2019. In this survey, education level we categorize into level, low, middle, and high. For low, it is used to formal education and elementary school. Middle is used to junior and senior high school, and high for higher education, include diploma or above. For both of the WIF in 2015 and 2019, more than 50% of respondents have middle educations. And then for the main occupation of Sleman HDSS respondent, aged 15 to 64 years old in 2019, the third ranks of main occupation were private employee, 90.8%, second, labor, 15.8%, entrepreneur, 50%, and only 4.4% had civil servants. However, 20.8% of respondents were unemployed, with the age range distributions were 45 to 64 years old. And then for marital status of Sleman HDSS respondent aged more than 10 years old in 2015 and 2019, more than 50% married and not more 2% had a divorce. For health insurance ownership in 2015 and 2019, started in 2015, highly increased from 60.63% to 81.03%. For additional information, in Indonesia, government started apply the national universal health coverage in January 2014. So the number of health insurance ownership highly increased in 2019. And the second topic about reproductive health, child and maternal health. Contraceptive use among respondents aged 15 to 49 years and whoever married in 2019. For female, the commons of contraceptive use in female was hormonal contraception injection. This followed by intrauterine device and hormonal contraception, pill, female sterilization, calendar-based method, implants, and withdrawal and lactation and female condom. But for the contraception use among male respondents, the common use were small condom, withdrawal, and calendar-based method, and male sterilizations. The next about gestational age at birth in 2016 and 2019. We can see in this orange color. In 2016, 40.63% the respondent severe preterm condition, and 2017 and 2018 was decreased to 17.65%, and in the middle in 2019 higher increase to 31.75%. For your information, in 2019 data collected until the middle of the years. And the age of the mother at the time of the delivery in 2016 and 2019, you can see in the green color. The age of the mother at the time of delivery, we still have mother who delivery less than 20 years old, and the number, although the number is not high, but still under 5%. And then for the trend of delivery method in 2016 and 2019, for the normal per vaginal methods, in 2016-2019 was decreased from 73% to 61.54%, but for sexual cesarean methods increased from 24.5% to 38.46%. The next about breastfeeding, complementary feeding practice, immunization, vitamin A supplementations. Percentage of children more or similar 6 months exclusive breastfeedings from 2016 to 2019 slightly increased from 42.7% to 60.2%. And then for early initiation of breastfeeding in 2019, there were 19.18% the baby have experienced early initiation of breastfeeding. For complementary food of children 0 to 23 months in 2019, for children less than 6 months old, they receive 4.77% receive milk breast, and they receive fruits 5.24%. For complete basic immunizations covered by vaccination 2016 and 2019, almost all the type of vaccination almost 100%. The types on the basic immunization in our country include hepatitis B, BCG, diphtheria, pertussis, tetanus, polio, and measles. And then for non-compulsory immunization for children under 5 years old in 2019, not more 4% of children they receive non-compulsory immunization. The kind of non-compulsory immunization in this research about rotavirus, pneumococcus, influenza, varicella, hepatitis A, and typhoid. For your information, non-compulsory immunization not supported by governments. So the prevalence or percentage of coverage is still under 5%. The next about vitamin A supplementation in 2019. The children who receive vitamin A supplementation for 12 months until 59 months higher than 6 until 11 months. And then for our government have regulation to provide the children vitamin A supplementation in every February and August. For non-communicable disease and non-communicable disease risk factor, firstly, we talk about the prevalence of communicable disease in 2016 and 2019. We start in 2016. In 2016 to 2017, is highly increased from 4% to 10%, and after that, they started decrease in 2018 and 2019. However, for dengue fever and tuberculosis, the respondents have diagnosed by doctor not more 1% in Sleman. The next about non-communicable disease prevalent among respondents aged more than 25 years. In 2016, NCD data were obtained from main respondents, but in 2017, NCD questions were asked directly to sample respondents. In 2016, the third range of prevalent non-communicable disease, firstly hypertension, 12.12%, and then followed by diabetes mellitus, 3.36%, and asthma, 2.55%. And then in 2017, the prevalence of non-communicable disease, the high rank in hypertension 19.42%, followed by diabetes mellitus 5%, and angina 2.95%. The next about risk factor for NCD. First, risk factor about prevalence of smoking in 2017 and 2018. Both of the survey, the smoker respondent were 20%. And then for the next risk factor about food and vegetable consumption and physical activity level, 77.8% the respondent had low intakes fruit and vegetable consumption, and 8.43% they had low physical activity. The next slide about top 10 causes of death in 2017-2019 with total deaths 700 to 21 people, with the first rank causes by circulatory system disease 30.10%, followed by respiratory disease, neoplasm, digestive disease, certain infection and paralysis disease, endocrine, nutritional, and metabolic disease, injury, indeterminates, genitourinary disease, and nervous system disease.
I'm sorry, Dr. Emma, I think you have trouble in connection because the screen is black currently.
Okay, is it clear?
No, we cannot see your presentation, I think.
I can see the
I
presentation.
can see.
Yeah, I can see the presentation.
You can see?
Yeah, I can see.
Okay.
Oh, okay.
May I continue my presentation?
Yeah, sure.
The last
Sorry.
topic about data collection in 2020, the aims to monitoring social, economic, and health status in Sleman during pandemic, method quantitative longitudinal study design, and conducted by telephone interview in September to November in 2020. The content module include update demographic data, impact pandemic COVID-19, socioeconomic impact, non-communicable disease, access of health facility, tobacco use, physical activity, and mental health. From the last survey, the response rate was 32.84%. And the first result for healthcare service utilization in 2017 and 2020, we quiz in this part 30.5%.
I'm sorry, Dr. Emma, I think your screen freeze because several participants cannot see. The slide is static at the prevalence of communicable disease.
Okay. I will move. Okay. Is it clear?
Yes, currently, yeah. Now we can
Yeah,
see
okay.
the healthcare service utilization slide.
Okay, sorry. For healthcare utilization, healthcare service utilizations, there were 30.5% of respondents. They decided to not seeking health treatment with the reason 87% not sick enough, and 11.92% afraid contracting COVID-19. Compared to the previous wave, the respondent in 2020, they prefer to access pharmacy and private hospital and public government. However, they lack of access to public hospital and primary healthcare center. And then impact of pandemic COVID-19, 39% of respondents worry about losing their jobs. And for type of expenditure that increased that most during the pandemic COVID-19, the grocery was the major type of expenditure, 31%, and followed by communication expenditure, fuel, health, electricity bill, ready-made food, and public transport. The next about support during the pandemic COVID-19, 54.6% respondent received government donation, and 10.9% received NGO private foundation, and followed by friend and neighbors and family. The kind of support commonly as cash or money donations, and followed by staple foods, a suspension or elimination of financial obligations. And then prevalence of smoking in 2018, 2019, and 2020. When we see this picture, the smoker, I think, is slightly decreased because from 20 to 16%. However, changes in smoking activity of smoker and a smoker during the COVID-19, they decrease to 28.9%. And then for prevalence of physical activity level in 2018 and 2020, I think slightly difference, because for high physical activity, they reduce only from 74 to 70%, and moderate physical activity increase from 70% to 21%, and low physical activity, I think, is slightly difference. However, changes in physical activity during the COVID outbreaks in 2020, the physical activity decreased to 31.21%. And the last slides, mental health problem in individual panel in 2019 and in 2020. Mental health problem increased from 11% to 20%, with the major symptoms was anxiety symptoms in these ones, and followed by cognitive symptoms, somatic symptoms, decrease of energy symptom, and depressions. Okay, I think it is limited time, so I cannot show all the data. We welcome you to discuss later. Thank you very much. Thank you, Dr. Lutfi. I'm sorry.
Yeah,
I moved to move from my first location.
Okay, thank you so much, Dr. Ema, for the comprehensive presentation of Sleman HDSS data. Now, there are several questions in the chat box. We move to the next session, the discussion session that will be facilitated by Dr. Gadjah Fahira. She is the team leader of Data Utilization Division in Sleman HDSS, and she holds a doctoral degree in immunobiology from the Vrije University in the Netherlands. Her research focus are on molecular epidemiology, Epstein-Barr virus, nasopharyngeal carcinoma, smoking-related diseases, and she also the chief of the biobank in the faculty. Please welcome Dr. Gadjah Fahira to lead the discussion.
Thank you very much, Dr. Lutfi, for your kind introduction. Good morning and good afternoon, everyone in Gothenburg and in Yogyakarta. Now we are we've seen two interesting presentations today explaining about HDSS and the rich data content in HDSS, on which potential of analysis and collaboration can be made from the data. We have like 15 minutes or 10 minutes of discussion. We have two first questions from Gothenburg asking about whether there are data related to HPV vaccination, as well as information collected on the use of antibiotic, as well as what is it? One moment, we can read the antibiotic or antimicrobial use. Perhaps Dr. Ifta or Dr. Ema can answer. Or I think it's better to answer by Dr. Ema.
Oh, okay.
For both questions.
I can also answer.
Yes,
Or
please.
Dr. Ema, yeah.
Kita dulu, saya baru ada.
Okay, yeah, thank you, Idris, for your question. So We actually doesn't ask question about HPV vaccination among young girls, but considering also the prohibitive cost of HPV vaccination, it's not already in the national immunization program. Although I think the government is starting to consider implementing, adopting it in the national immunization program, but it's not there currently. And if you want to get HPV vaccination in Indonesia, you have to go to a private clinic, and it's now very costly. It's maybe for regular Indonesian household, it can amount to a quarter of their monthly income. So I don't know if there are a lot of young girls or boys are vaccinated with HPV. And also, we have just started including question about cancer in the last cycle, in the 6th cycle. Before, we only ask the questions on hypertension, diabetes mellitus, coronary heart disease, stroke, and I think what's the other one? I forgot, because those are the most common non-communicable diseases presented in the primary healthcare and other health facilities. But in the 6th cycle, we ask in the individual module whether they have ever been diagnosed with cancer. And then we ask what type of cancer that they're diagnosed with. And the options are cervical cancer, and then breast cancer, prostate cancer, colorectal cancer, lung cancer, and bronchial cancer, nasopharyngeal cancer, and then cancer of the blood or leukemia, because that's all the most common cancer in Indonesia. And then there is also option other type of cancer, and they were asked to mention the type of cancer they're diagnosed. And then also the follow-up question is whether they take medication in the last 2 weeks for their cancer, or whether they undergo any other care, medical care for their cancer in the last 12 months. But also, as a reminder, on our 6th cycle, our response rate is only like 30%. So it's not, maybe not representative of the overall HDSS population for that year.
And for second question, for the use of antibiotics and antimicrobial.
So the questions on infectious diseases, the way we ask the question is asking the knowledgeable member of the household about the condition of other household member in the last 1 month. So we ask the common communicable diseases in Indonesia that is a concern among healthcare provider and the government. Yeah, so we ask about upper respiratory infection, malaria, and then dengue fever, because this is in Indonesia, Yogyakarta, there are a lot of dengue fever, and also leptospirosis. We also ask whether somebody in the household diagnosed with TB, because Indonesia is also a priority for TB prevention and control. And I think what's the other one, but we don't actually ask about those specific questions, whether they got medication for those upper respiratory infection or leptospirosis, but we do ask whether they got anti-malaria medication if they're diagnosed with malaria, or if they are diagnosed with TB, whether they are currently on medication, or whether they drop out from medication, or whether they finish their medication. But we don't ask what are the antibiotics they're prescribed or they use.
Thank you, Dr. Ifta. It feels like I am talking to a living dictionary. And it's kind of the completeness that we have, on which, as was written down in your invitation for for Google Classroom. I believe there are a list of variables that collected during our different cycles every year. You can further look through it. Thank you very much for Idris and Syamaka. And the third one is question. If somebody wants to use the data from HDSS Sleman for thesis preparation or else, what are the requirements? Dr. Ema, please.
Okay, thank you very much, Bu Yaya. For Alfie Purwanti, if you're interested to use the Sleman HDSS, you can visit website you can visit Sleman HDSS or contact us, and you can learn how to access and how to identify the variable. Everything is complete in my websites. And if you have a difficulty to learn about that website, you can contact us. It is more clear to explanation how to use the access the website Sleman HDSS. Is it clearly for Alfie Purwanti?
Yes, Miss, thank you.
Okay, welcome.
Thank you very much. And the next is, do you have data about prevalence of COVID-19 on specific group like young group, for instance? Dr. Ema.
Okay, I think I asked Nia to help our Putri to answer these questions.
Okay, we have our management team and also HDSS staff to help us answer some questions. Silakan, Mbak.
Yeah, about the question about COVID-19 prevalence, if I'm not mistaken, can you move back to the slides before? Yeah, unfortunately, I think we didn't collect data on whether someone is infected with COVID or not in the last cycle. So no, we don't have the data on that.
Okay, thank you, Ania, for your answer. Now I open for like one or two question, direct question for our speaker and our team. Please do, who'd like to, you can raise your hand virtually for a direct question.
So maybe if there is no question for the time being, I also can add, we don't include the questions about whether they have been infected or diagnosed with COVID in the last cycle. It's also in the beginning of the pandemic. But we do ask about the socioeconomic impact of COVID in the last cycle. But we also include in the individual module, actually we include a question for individual whether they experience symptoms related to COVID and whether they have been diagnosed, as an introduction to questions about acceptance to vaccine, because we include those questions in the next cycle. So hopefully the next cycle, we started just this week after delay by the surge of Delta variant. So hopefully we will be able to complete our data collection and the response rate is higher than the last cycle. Thank you.
Thank you, Dr. Ifta. Due to time limit, any last question? Otherwise, again, or perhaps Dr. Fatwa, you'd like to add something to the workshop?
Yeah, perhaps adding a little bit about COVID-19 data collection that cannot be, we couldn't collect in 2020 because it was in the beginning of the pandemic. And it was a quite sensitive question asking about the symptom of influenza, for example. So we do not want to scare people and reduce their participation. That is the reason why. And another thing, perhaps looking at the question of the participants, it might reflecting that the want to know what kind of topic is possible for further study, and it is might not easy for this very short workshop, I believe, because we have about 5 million, ya Mbak Nia, ya, 5 million data, so it's like swimming on numbers. That is why I think it is good if you want to know further, you can explore from the module that is already shared on the Google Classroom, and you can think furthermore what can be what kind of topic that is possible for you to study further, and perhaps Monica can also give you some direction on how to use secondary data that is already collected. So we need to adjust our topic to the possible data that is possible, that is available on the data set. Okay, thank you very much.
Thank you, Dr. Fatma. Monica, please, would you do you like to share your insight on this?
Yeah, absolutely. Thank you. Thank you for a nice presentation of everything that you've been doing. And Salman, that's very interesting. We made a plan yesterday to move forward for the students at University of Gothenburg. The next step, if you're interested in working with the HDSS Sleman data, will be to attend a workshop that's going to be held in October. And in that workshop, we can start to explore topics more deeply. So my suggestion would be to use the rich materials that have been provided in the Google Shared Drive and to look at the variables. And then we're going to be sending out an invitation for the end of October. We're still deciding on the precise date, but in that workshop in October, we'll dig deeper into topics that you could explore for thesis work. And that workshop will be followed by a second workshop in November. So today was just meant to be an introduction to the rich data set that's available to work with. So thank you very much for that. And for the students at Gothenburg University, you'll see an invitation from us soon.
Thank you so much for all our speakers and our team leaders for this first meeting. And everybody can learn so much from the data shared in our Google Classroom. And I would like to close this QA part by sending the forum back to Lutfi. Thank you very much, everyone. Hopefully you will get benefit from our at least first workshop, and good luck.
Thanks, everyone.
Thank you so much. Thank you so much, Gadjah, for facilitating the discussion. Now we come to the end of our workshop, but we have several announcements for the participants. So this workshop is being recorded, and you can find the recording of this workshop in Sleman HDSS YouTube channel. Maybe the committee will share the link in the chat box to access the YouTube channel. And do not forget to fill the attendance form to verify your data, because we will provide the certificate of participation and it will be sent to you via email. And should you have any further questions regarding to the data, to the variables, please do not hesitate to send your question to Sleman HDSS email, as well as you can also post your question in the comment section in the Google Classroom. Last but not least, to commemorate our workshop, I invite you to open your camera to take a picture, put your best smile. The committee, please help to take the picture. Mbak Ratri or Mbak Putri, would you like? Could you please help to take the picture?
Yes. We will wait several people to open the video for 1 second. I will count 1, 2, 3. Please hold. Once more. 1, 2, 3. Please smile.
Finish, Mbak Ratri?
Yes, thank you so much.
Thank you so much for your participation in this workshop, and we hope that this workshop will be produce one or maybe several manuscripts or research project, and we are very happy to assist you in exploring the data and the material. All the materials from this workshop have been provided in the Google Classroom. Thank you so much for your participation in this discussion. I wish you all a nice day and goodbye.
Okay, bye-bye.
Bye everyone, take care.
Thank you,
Thank you so much.
Bu
Thank
Yaya,
you.
Bu Fatwa, Monica.
Yeah, thank you also.
Bye, everyone.
Bye.
Bye.